Welcome to the deep dive. What we do here is take complex stuff articles, research, you name it, and pull out the nuggets. The really important, surprising, actionable insights for you. Today we're jumping into cardiovascular health. Your heart, your blood vessels, the whole system. Our mission, give you those aha moments. Help you get genuinely informed without getting totally swamped in details. It's your shortcut. Okay, so let's unpack this. Maybe starting with the basics. Prevention, management. Especially around cholesterol management, right?
Right. And it's key to know there are really two paths here. Primary and secondary prevention. Primary is, it's about stopping the disease before it starts. For people with risk factors, high cholesterol maybe, or high blood pressure, but no actual disease yet.
Like building a fence, kind of.
Exactly. Then secondary prevention is for people who already have diagnosed ASCVD, that's atherosclerotic cardiovascular disease. For them, we're using treatments, mostly statins, to prevent more events. Heart attacks, strokes, and how we decide who gets what. It really comes down to personalized risk, using ASCVD risk calculators.
Okay, statins. You mentioned statins. They seem to be the main tool here for cholesterol. What should we know about them?
Yeah, they're definitely the workhorses. They mainly lower your LDL cholesterol, the bad cholesterol.
The sticky stuff in the arteries.
That's a good way to put it. Statins slow down your liver's production of it and help clear out what's already there. We talk about them in terms of intensity, low, moderate, high, how much they lower the LDL. And the intensity you need depends on your risk. Someone with really high LDL or maybe diabetes probably needs a high-intensity statin.
Right.
It's also worth knowing different guidelines, like from the ACC or USPSTF, might have slightly different thresholds for starting statins based on that ASCVD risk score.
Got it. Okay, moving on. Hypertension, often called the silent killer. Why that name, and how's it actually diagnosed?
Well, silent killer is pretty apt because often there are zero symptoms until real damage is done. That's why regular checks are so important. Diagnosing it isn't just one high reading either. You need an average of at least 2 high readings, taken on at least 2 separate occasions.
To avoid the white coat effect and things like that.
Exactly. And for stage 1 hypertension, the first step is almost always lifestyle changes. Diet, exercise, stress, that stuff can be powerful. But if your ASCVD risk is high, then medication often starts right away alongside those lifestyle changes. The main first-line drugs. We're looking at ACE inhibitors, ARBs, calcium channel blockers, and thiazide diuretics.
Okay, quite a few options there. And this is where it gets really interesting, right? Are there times when one is clearly better than another? What are those specific situations?
Oh, absolutely. It's not one size fits all. For example, if someone has diabetes or chronic kidney disease, we often lean towards ACE inhibitors or ARBs.
Why those specifically?
Because they do double duty. They lower blood pressure, sure, but they also have this kidney protective effect. They kind of relax the blood vessels in the kidneys, which is a huge benefit.
That's fascinating.
Yeah. And then maybe someone has osteoporosis. Well, thiazide diuretics might be a good thought there. They actually stimulate osteoblasts. Those are your bone-building cells. So another potential dual benefit.
Wow, okay. And one really critical point, absolutely non-negotiable, ACE inhibitors and ARBs cannot be used during pregnancy. They're harmful to the fetus. So in pregnancy, we'd use safer options like nifedipine, labetalol, or methyldopa.
Good to know. Crucial, actually. So we've hit the big ones: cholesterol, blood pressure. What else is lurking out there that we need to be aware of? Other key factors.
Definitely. We can't forget elevated triglycerides. People often lump them with cholesterol, but really high levels like over 500 bring a serious risk of acute pancreatitis.
Inflammation of the pancreas.
Exactly. Especially if combined with alcohol. So it's not just about the heart. Then there's abdominal aortic aneurysms, or AAAs. This is a bulge in the main artery, the aorta, down in your abdomen. Screening is recommended specifically for men aged 65 to 75 who have ever smoked. Even just one cigarette counts.
And what's the critical thing to know there?
The warning signs of a rupture. It's sudden, severe abdominal or back pain, often with low blood pressure, and you might even feel a pulsing mass in the belly. That's a true emergency. Need surgery fast.
Okay, wow. And finally, metabolic syndrome. It's not one disease, but a cluster of things. Abdominal obesity, high triglycerides, low HDL, the good cholesterol, high blood pressure, and high fasting blood sugar. Having this cluster dramatically raises your risk for both type 2 diabetes and cardiovascular disease. They all feed into each other.
And then treatment starts with?
Back to basics again. Lifestyle changes and weight reduction are first line. It all connects.
Incredibly insightful. Okay, we've laid the foundation with prevention and these other risk factors. Now let's get into the heart itself. The engine. How does it actually work? Structure, sounds?
Yeah, let's visualize it. The heart's orientation is a bit funky. The base, where the big vessels connect, is actually at the top. The apex, the pointy part, is at the bottom, tilted a bit left.
Okay, base at the top, apex at the bottom. Got it.
And blood flow, it's this elegant loop. Deoxygenated blood comes from the body into the right side, gets pumped to the lungs for oxygen. Then that oxygen-rich blood comes back to the left side, and whoosh, the left ventricle pumps it out to the whole body. This cycle has two key phases. Diastole, that's when the ventricles relax and fill up, like recharging. And systole, that's the big squeeze, when the ventricles contract and push the blood out.
And the sounds we hear, that classic lub-dub. What's actually making those sounds?
Those are your S1 and S2 sounds, and they're literally the valves closing. The lub, S1, is the closing of the AV valves, mitral and tricuspid. Those are the doors between the top chambers, the atria, and the bottom chambers, the ventricles. You hear S1 best down at the apex.
Okay.
The dub, S2, is the closing of the semilunar valves, aortic and pulmonic. The exit doors, basically leading out to the body and lungs. You hear S2 best up at the base. There's a handy mnemonic for remembering where to listen. All people take money. Aortic, pulmonic, tricuspid, mitral, tells you the spots on the chest.
APTM. Nice. Now, what's truly fascinating is when you hear other sounds, right? Those extra beats or murmurs. What are those telling us?
Exactly. Beyond the normal lub-dub, sometimes you hear extra things. An S3 sound, sometimes called a ventricular gallic, can happen with volume overload. Think heart failure or even pregnancy sometimes. It's kind of a faint lub-dub-dub, best heard at the apex.
Okay, volume overload.
Then there's S4, the atrial gallop. Sounds more like lub-lub-dub. That happens when the atrium pumps blood into a stiff ventricle that doesn't want to relax properly. Common causes are things like uncontrolled hypertension or left ventricular hypertrophy where the heart muscle is thick. Or sometimes it's just benign aging as the heart naturally stiffens a bit. Also best heard at the apex.
And you mentioned a split S2. What's that?
Right. Normally, the aortic and pulmonic valves, S2, close almost together. But when you breathe in, the pulmonic valve closure can be slightly delayed. That creates a split sound, lub-de-dub. If that split only happens when you inhale, it's usually normal, physiological. But if you hear that split sound during both inhalation and exhalation, a fixed split S2 that's abnormal, that needs a cardiology referral. It suggests something else is going on.
That's a really subtle but important distinction.
Okay.
Okay, then there are murmurs. They seem complex. What's the absolute key takeaway about murmurs?
Murmurs can be complex, but here's the most critical rule. Diastolic murmurs are always pathological. Always.
Always bad news.
Pretty much. My old professor had a tip. Diastolic equals do, as in do referred to cardiology, no exceptions. If you hear a murmur during diastole when the heart's relaxing, it needs investigation. A mnemonic for common ones is Mrs. Arch. Mitral stenosis and aortic regurgitation are diastolic murmurs. Aortic regurgitation is usually early diastolic, kind of a flowing sound. Mitral stenosis is more mid-diastolic, low-pitched, maybe a rumble.
Okay, diastolic equals do refer. Got it. What about systolic murmurs, the ones during contraction?
Systolic murmurs are more common and can sometimes be benign or physiologic. The mnemonic here is Mr. PAS MVP. Mitral regurgitation, physiologic, aortic stenosis, systolic, mitral valve prolapse. Now, some key systolic ones to know. Aortic stenosis. This one is super important because it often radiates, the sound travels up towards the neck, the carotid arteries. That's a classic sign.
Radiates to the neck, okay.
Mitral regurgitation. This is usually how systolic lasts through the whole contraction, often high-pitched, and it radiates towards the armpit, the axilla. And mitral valve prolapse often has a distinctive click sound associated with the murmur. We also grade murmurs 1 through 6. If you can actually feel the murmur vibrating on the chest wall, that's called a thrill. It's at least a grade 4. That indicates a pretty significant murmur.
That's incredibly helpful for sorting through those sounds. Okay, let's shift to a really major condition, heart failure. It affects so many people. What does it actually mean when someone has heart failure?
Yeah, heart failure, or HF, basically means the heart isn't doing its job properly. Either it can't pump enough blood out to meet the body's needs, or it can't fill up with blood effectively between beats. It's a failure of the pump mechanism. The most common type is left-sided heart failure. This involves the left ventricle, the main pumping chamber. When it fails, blood and fluid tend to back up into the lungs.
So L for left, L for lung.
Exactly. That's a great way to remember it. Symptoms are mainly respiratory shortness of breath, trouble breathing when lying flat, coughing. And within left-sided HF, there are 2 main subtypes. Systolic HF, or HFrEF, heart failure with reduced ejection fraction. Here, the pump is weak. The left ventricle isn't squeezing effectively. The ejection fraction, which is the percentage of blood pumped out with each beat, is low, usually under 40%.
Less efficient pump.
Right. Then there's diastolic HF, or HFpEF heart failure with preserved ejection fraction. Here, the squeeze might be okay. EF is usually over 55%, but the ventricle muscle is stiff. It can't relax properly to fill with blood. So it's a filling problem, a stiff pump problem.
And between 40 and 55% is
Kind of a grayed area, sometimes called mildly reduced EF. The principles are similar, though. Now, right-sided heart failure is less common on its own. Usually it develops because of left-sided HF. All that backed up pressure from the lungs eventually puts strain on the right side.
domino effect.
Pretty much. And for right-sided HF, think R for right, R for rest of body. Symptoms show up elsewhere, like swelling in the legs and ankles, peripheral edema, or fluid buildup causing abdominal swelling, maybe bulging neck veins, that's JVD. And one more term, acute decompensated heart failure. That's when someone with chronic HF has a sudden, severe worsening of symptoms, or it's the first time symptoms appear acutely. They often end up in the ER, usually very short of breath, overloaded with fluid.
Okay, that covers the types. It sounds quite serious.
Okay.
So if heart failure is suspected, how do doctors figure it out? What's the diagnostic workup?
It's a multi-pronged approach. We do blood tests, that's EBC, a metabolic panel checking kidney and liver function electrolytes, and very importantly, BNP, B-type natriuretic peptide.
That's that hormone you mentioned.
Exactly. The heart releases it when it's stretched and stressed. High levels strongly suggest heart failure, especially in an acute setting. It's like a distress signal. Imaging is crucial too. An echocardiogram and ultrasound of the heart is key. It lets us see the heart structures, how the valves are working, and critically measure that ejection fraction. We also use chest x-rays, which can show fluid in the lungs or an enlarged heart, and an ECG to check the heart's electrical rhythm.
Right. And once it's diagnosed, what's the treatment approach? How's it managed?
Managing the fluid is usually priority number one. So diuretics are often the first line of treatment. Loop diuretics like furosemide, brand name Lasix, are very common. They work quickly to pull off excess fluid.
But you mentioned potassium earlier.
Yeah. Yes, that's the catch with loop diuretics. They make you lose potassium along with the fluid, so we have to monitor potassium levels closely, and patients often need potassium supplements. There are also potassium-sparing diuretics like spironolactone. These have a diuretic effect but also block aldosterone, a hormone that makes you retain salt and water, and as the name implies, they help hold on to potassium.
So you watch potassium for going too high with those.
Exactly. And monitor kidney function. Spironolactone also has a unique side effect in men gynecomastia or breast enlargement.
Okay, diuretics for fluid. What else?
Several other drug classes are pillars of HF treatment. ACE inhibitors, or the combination ARB neprilysin inhibitors, are vital. Beta blockers are also essential. And then there are the SGLT2 inhibitors. These were originally diabetes drugs, but they've shown amazing benefits for heart failure, even in people without diabetes. It's been a real game changer.
That's incredible, finding a new use like that. Now, this brings up a really important point for people managing this at home. What medications should absolutely be avoided? The red flags.
This is so important for anyone with heart failure or caring for someone who has it. 3 main groups to avoid. First, NSAIDs. Ibuprofen, naproxen, things like that, they can cause fluid retention and make HF worse. Big no-no.
Okay, avoid NSAIDs.
Second, TZDs, thiazolidinedinones. These are some older diabetes medications, and they also cause significant fluid retention. And third, certain calcium channel blockers, specifically the non-dihydropyridine ones like verapamil and diltiazem, they can slow the heart rate too much and weaken the pump.
So non-DHP calcium channel blockers are out.
Generally, yes. And even other calcium channel blockers need careful monitoring because they can cause edema or swelling.
Got it. Avoid NSAIDs, TZDs, and be very cautious with calcium channel blockers, especially non-DHPs. What about crucial home management tips, things people can do themselves?
Absolutely key. 3 main things. Daily weights. Get on the scale every morning. If you gain 2-3 pounds overnight or 5 pounds in a week, call your doctor. That's fluid building up.
Daily weights. Check.
Second, a low-sodium diet. Salt makes you hold on to water, so limiting sodium intake is critical to prevent fluid overload. And third, sometimes fluid restriction. Your doctor might give you a specific limit on how much liquid you can drink each day. It takes discipline, but it's vital for managing volume.
Daily weights, low sodium, maybe fluid restriction, simple but powerful. Okay, we've gone deep on heart failure. But the cardiovascular system is vast. What other important conditions affecting the heart or rhythm should we touch on?
Great question. Let's talk coronary artery disease, CAD, and acute coronary syndrome, ACS, first. CAD is that slow buildup of plaque in the heart's own arteries. It can cause chest pain, angina, especially with exertion. ACS is more sudden, more critical. It's usually when a plaque ruptures, forms a clot, and abruptly blocks blood flow. That's a heart attack or unstable angina. Immediate medical help needed.
And you mentioned atypical symptoms before.
Yes, crucial reminder. Especially in women, older adults, and people with diabetes, ACS might show up as fatigue, nausea, back pain, shortness of breath. Not always that classic chest pressure. Awareness saves lives.
Good point. What about rhythm issues?
Two common ones are atrial fibrillation, AFib, and supraventricular tachycardia, SVT. AFib is an irregular, often rapid heartbeat starting in the upper chambers. The big risk is stroke because clots can form in the quivering atria. So management involves assessing stroke risk, usually with anticoagulants, plus controlling the heart rate or rhythm.
And SVT.
SVT is a very fast, but usually regular, rhythm starting above the ventricles. It can feel quite alarming. Sometimes simple maneuvers like bearing down as if having a bowel movement can stop it. Other times, it needs ER treatment. Oh, and sinus arrhythmia. That sounds like a problem, but it's usually totally normal. It's just the heart rate naturally speeding up a bit when you breathe in and slowing when you breathe out. Common in healthy young people and athletes.
Okay, that's reassuring. One more one. Infective endocarditis. Sounds serious.
It is serious. It's an infection of the heart's inner lining, often the valves, usually bacterial. Big risk factors are IV drug use or having pre-existing valve problems. Symptoms can be fever, fatigue, but also look for specific signs like tiny, painless spots on palm soles, Janeway lesions, or painful nodules on fingertip stows, Osler's nodes. Suspect it. Get to the ER immediately.
Okay, that covers a lot of ground within the heart itself.
Wow.
Now let's broaden out one last time. What about the vessels elsewhere? Peripheral vascular conditions.
Right, the plumbing beyond the central pump. Let's start with peripheral artery disease, PAD. This is atherosclerosis, that same plaque buildup, but in the arteries of the limbs, usually the legs. Smoking is the #1 risk factor by far, the classic symptom. Intermittent claudication leg pain or cramping when you walk, that gets better with rest.
Because the muscles aren't getting enough blood flow.
Exactly. Other signs can be cool skin, weak pulses in the feet. We diagnose it often with an ankle brachial index, comparing blood pressure in the ankle and arm. Treatment involves quitting smoking, exercise, antiplatelet meds, and maybe seeing a vascular specialist if it's severe.
Okay, PAD is arteries. What about veins?
That brings us to chronic venous insufficiency, CVI. This is when the veins in the legs are damaged, often the valves inside them, so blood doesn't flow back to the heart well. It cools in the legs. You see swelling, varicose veins, skin changes like darkening or thickening, and it can lead to ulcers that are hard to heal or even blood clots like DVT.
And management for CVI.
Mostly non-drug things. Compression stockings are key. Elevating the legs helps gravity return the blood, keeping the skin healthy. Sometimes specialist procedures are needed. Then there's deep vein thrombosis. DVT itself. That's a blood clot forming in a deep vein, usually the leg. It can happen after surgery, long travel, injury, or sometimes for no clear reason, unprovoked. Presents as sudden swelling, pain, warmth, redness in one leg usually. Diagnosed with ultrasound. Treatment is crucial blood thinners, usually DOACs these days, to prevent the clot from getting bigger or breaking off.
Because if it breaks off.
It can travel to the lungs, causing a pulmonary embolism, which can be fatal. So DVT needs prompt treatment.
Right. One more Raynaud's. What is that?
Raynaud's phenomenon is quite different. It's about vasospasm, temporary exaggerated constriction of small blood vessels, typically in fingers and toes, in response to cold or stress. Causes dramatic color changes, fingers go white, then blue, then red as blood flow returns. Can be uncomfortable or painful. Treatment involves avoiding triggers, keep hands and feet warm, and sometimes calcium channel blockers to help relax those blood vessels.
Wow. We have covered an incredible amount of ground today. From prevention strategies for cholesterol and blood pressure, decoding those heart sounds and murmurs, understanding the complexities of heart failure, other key cardiac conditions, right out to the peripheral vessels with PAD, CVI, DVT, and Raynaud's. You, our listeners, have hopefully gained a much deeper, more practical understanding of this vital system, those aha moments we talked about.
Absolutely. And maybe a final thought to leave you with. Consider how just knowing about these specific symptoms and signs, the radiating pain of aortic stenosis, the leg swelling in right heart failure, the claudication in PAD empowers you. It helps you listen to your own body or notice things in others with more insight. What might seem like a small, unrelated issue could actually be a critical signal from the heart or vessels, pointing towards a bigger picture. Knowing what to look for really does transform simple observation into potentially life-saving insight.